Welcome to ATCM, the Emergency Medicine channel. Today we are going to have a clinical discussion on a case presented to emergency room. Dr. Pranay will be presenting the case. Can we start, Pranay?
Yes.
Please
With
start.
your permission, sir. Presenting a case of a 61-year-old gentleman who was rolled into the ED by the paramedics into the immediate care room. On arrival, patient's initial 10-second assessment revealed that patient is in an unresponsive state. So a mandatory pulse check was done according to BLS protocol. Central pulse was present. Patient was breathing, but patient was having an abnormal breathing pattern, and patient sensorium assess revealed as a very low Glasgow Coma scale, which is E1 V1 M2. So immediately I've asked my staff to make the patient lie down on a couch and arrange for rapid sequence intubation.
Can you tell what are the reasons for unresponsiveness in emergency room?
Sir, there are several causes of unresponsiveness in the emergency room. Most commonly encountered include metabolic causes such as hypoglycemia, hyponatremia, or it's CNS insults such as intracranial or massive extracranial bleeding causing diffuse cerebral edema, or severe traumatic brain injury, or ischemic stroke causing severe cerebral edema, etc. Then other causes of unresponsiveness include cardiac arrest.
Okay.
Cardiac arrest is also another cause of very important cause of unresponsive state. Then other cause of unresponsive state include toxins such as opioid toxicity, benzodiazepine toxicity, severe ethanol or methanol toxicity, etc. can cause unresponsive state. These are called toxic metabolic.
So the most important thing is hypoglycemia.
Yes.
So once you do the sugar test, you can go ahead for rapid sequence intubation.
Yes.
So sometimes hypoglycemia, if you intubate, then you'll be missing the hypoglycemic part.
Yes.
So that is the most important investigation in emergency room before going for an intubation in low GCS case.
Yes. So immediately a random blood glucose was checked at this patient's bedside. Capillary blood glucose revealed 69 milligram per deciliter. Concurrently, I have asked for my assistant to get a brief history from the available bystanders. So patient was put on continuous cardiac monitoring. His blood pressure and heart rate was measured. Blood pressure was at this point 160 over 100, and heart rate was 100, and he was also febrile. So I asked my staff all to don a level 2 personal protective equipment because of ongoing COVID infection. So we have all worn personal protective equipment.
Okay.
And approached the patient before touching or going near the patient.
Okay.
So then after putting on personal protective equipment, we have arranged for the intubation, that is by rapid sequence intubation. I've asked for a senior emergency consultant to be beside me while intubating the patient, and continuous cardiac monitoring is ongoing, and 2 large bore IV access is also achieved at this point.
So apart from cardiac monitoring, do you think any other monitors is essential when the patient is arriving?
We need to monitor the saturation, the oxygen saturation in ambient air as well as with supplemental oxygen.
So the placement of the pulse oximeter.
Yes.
Okay. Then
we've also done
before going to IV line. So how will you proceed actually?
Sir, we have to
ABC.
We have to take care of the airway immediately. For that, we need 2 IV access to administer drugs for the intubation. So for the airway, since I'm not expecting a difficult airway in this patient did not have any morbid obesity or suspected obstruction or any surgery to the neck. So I'm not anticipating any difficult airway at this point. So
what is oxygen saturation?
Yeah, oxygen saturation at that point when he arrived was 93% in ambient air.
Okay.
And so I've supplemented with oxygen.
You have to tell about the attachment of the pulse oximeter.
Yeah.
And necessary, you have to immediately put an oxygen mask at least.
Yes.
Okay. Oxygenation should go
Yes.
from the beginning itself.
Yes. Yeah. So supplemented with oxygen via face mask and supplemented oxygen 4 liters to maintain saturation above 94%, and with ongoing cardiac monitoring, I've arranged for all intubation drugs. I've asked my staff to arrange for fentanyl 3 microgram per kilogram body weight.
Why you
as an
selected fentanyl? Can you tell the reasons for fentanyl?
Sir, fentanyl is an ideal agent given as an analgesic and an anxiolytic for as a pre-medication for intubation.
Okay.
Because several of the intubation induction agents do not have analgesic effect, so we need to add an analgesic, and fentanyl has a potent analgesic effect. So I have asked for fentanyl 3 microgram per
Can you tell
kilogram.
some of the induction agents which are not having a analgesic property?
Sir, most induction agents do not have analgesic effect including propofol, etomidate, and thiopentone, etc. The only drug which is having analgesic effect is ketamine, which is a versatile drug. But in severely raised ICT and intraocular tension, we try to avoid ketamine. And when the patient is having severe ischemic heart disease also, we try to avoid ketamine.
How do you want to avoid ketamine in ischemic heart disease?
Sir, it increases the increases the myocardial oxygen demand. It increases the heart rate.
That is more important.
It increases the heart rate. So
whenever you have ischemic heart disease, pulmonary edema, we have to avoid this drug.
Yes, we have to avoid ketamine. And for all rapid sequence intubation, etomidate is generally considered the safest agent. And our choice is around 0.2 to 0.3 milligram per kilogram body weight. And it is a agent of choice in adults.
Okay.
And there is no absolute contraindication to etomidate. So I've asked for fentanyl 3 microgram per kilogram, and assuming that the ideal body weight of this patient is 60 kilograms, so I've asked for around 150 to 150 microgram of fentanyl.
Okay.
Along with that, I have also asked for a antiemetic, ondansetron 0.1 milligram per kg. So I have around
68 milligram it comes.
Around 6 milligrams or 8 milligrams I have given ondansetron. Along with that, I have induction agent. I was chosen etomidate 0.3 milligram per kg. So I have asked for 20 milligram of etomidate, and paralytic agent I have chosen as rocuronium at this point because of the rapid onset and rapid action. So
okay, you are telling all about your preparation for the intubation,
yes,
rapid sequence intubation.
Yes.
What is the airway and breathing? You have not enlightened anything regarding these two.
Sir, this patient, since his sensorium is on the very low side, we have is also having a gurgling sound. So upper airway obstruction is.
What is the cause for the gurgling sound? What do you suspect?
Sir, because of increased secretions, he is not able to manage the secretion. That is, his protective airway reflexes are diminishing.
And did you intervene anything?
Yes, at this point, I have placed a nasal airway to temporize the airway at this point. And while placing the nasal airway, I have given supplemental oxygen also.
Okay, see, he's a 60-year-old man. See, he is in an unresponsive state.
Yes.
See, apart from the gurgling sound, any other thing with regard to the airway assessment?
Fallen tongue.
Did you
Yes, there was
that?
There was no fallen tongue, but the secretions were increased at this point.
So for that you put the nasal catheter.
And we put the nasal catheter and we did a airway clearance also with suction.
Airway clearance?
With suction assisted airway clearance
Very
we did.
good. Okay, good.
So suction assisted airway clearance we did, and while the drugs were being loaded, supplemental oxygen was given, and at the same time patient's vitals were frequently monitored. Okay. And patient was observed for any incidence of seizures or any other.
1 minute. See, you are giving the nasal oxygen. Okay. You are checking everything. You did not talk anything about the breathing.
Breathing.
You assess the airway.
Yeah.
That is okay. Next one is breathing.
Yeah, breathing, sir. He's having he's taking breaths, but it's a altered breathing pattern is seen. So
what type of breathing pattern you get in raised ICP?
Sir, raised ICP, we get a breathing, we get a Kussmaul's type of breathing with altered breathing pattern. So a waxing and waning type
Correct.
of breathing can be observed.
So this patient, you observe something like that?
Yeah, we observed a waxing waning pattern with the frequent episodes of apnea also. So
there is a raised ICP. what are the precautions you take when you intubate? That's what Sar is asking.
Yeah. So when the patient
First, please tell me how will you assess the breathing aspect?
breathing aspect, you have to look for the depth and the rate of the each breath. Adequate breathing will be in the range of 14 to 16 breaths in an
What is
adult.
the respiratory rate?
Respiratory
Okay,
rate.
then?
And you should look for symmetrical chest rise.
Okay.
You should look for any paradoxical breathing movement. You should look for any hyperventilation or hypoventilation. You have to look for or bradypnea. Or at the same time, you should look for any abnormal breathing sounds also. Or if the patient is having audible rhonchi or audible wheeze, or then you have to look at the same time. You have to continuously monitor the saturation via pulse oximeter.
Was the chest excursions were adequate?
Yeah, chest excursions were symmetrically adequate.
What is the rate of the respiration?
So respiratory rate was in the range of 12 to 14.
You
breaths.
told there had been in between apneic
Yeah,
spells
in
also.
between
How
apneic
did
spells.
you check the respiratory rate?
A complete manual count in a period of 1 minute.
1
was done.
minute,
Yeah.
okay. See, we can count for 15 seconds and you can multiply into 4.
4, yes.
Can we do it?
Not in this patient because he's having an altered breathing pattern.
After breathing, in between apneic spells are there.
Yeah.
So this will not be giving a correct rate of it. So in such patients, do you think nasal oxygen itself will oxygenate the patient?
No, because there is a period of apnea. So apneic ventilation, we should take care of the ventilation.
How did you manage?
So I've after placing the nasal airway and supplemental oxygen, saturation was improved to above 94%, and I've administered the antiemetic ondansetron, and along with that slowly administered fentanyl to diminish the effects of intubation, the vagal stimulation because of the
No,
intubation.
before that, we have not yet finished the airway and breathing. Okay, so breathing we are considering.
Yes.
Okay, you are telling in terms of the secretions are there which have been cleared.
Yes.
So do you think do you have to proceed with some maneuvers to open the airway?
Sir, while placing the nasal airway, we had done a head lift and head tilt and chin lift.
Was there any history of fall?
There was no history of
Unconscious.
trauma.
Okay.
There was no history of trauma per se.
Okay.
So and then proceeding with intubation. So after
No, 1 minute, 1 minute. So you cannot jump.
Okay,
The
sir.
patient has to be given at least 3 minutes oxygenation,
Yeah.
pre-oxygenation.
Yes.
Whether patient's breathing is not all right.
Okay.
Whether the nasal cannula of administration of oxygen will take care of it,
No.
or you have to go for any other means.
Yeah. Since patient is having apneic spells, we have to take care of the ventilation. We have to assist with the bag and mask ventilation. So bag and mask ventilation. So I've started bag and mask ventilation after administering fentanyl. After administering fentanyl started bag and mask ventilation, and there was adequate chest rise, and saturation
Why do you
improved.
differ from applying a mask, oxygen mask, instead of you have applied the nasal cannula?
No, I have applied face mask, sir, over the nasal airway. He had a nasal airway. On top of that, we placed a face
you
mask.
have to tell everything complete.
Yes.
See, airway means how to assess. So you mean any life threats, immediate management, correction of the life threat.
Yes.
Then you go for breathing. This should be going in an order.
Yes, sir.
Which order you will be always doing the primary survey?
Always with airway. Then if it's a trauma victim, you should take care of the cervical spine, and then next would be the breathing, next will be circulation, next will be disability, and then last exposure.
Will there be any alteration from this ABC at any situation?
Yeah, when patient is having a cardiac arrest, we always take care of the circulation first.
CAB.
Yeah.
Apart from cardiac arrest, any other situation?
Where circulation is more important.
More important.
When patient is having severe shock or cardiac arrest with
Massive external visible hemorrhage.
exsanguination.
So hemorrhage control in such cases.
Yes.
Okay. So 2 occasions. One is cardiac arrest, cardiac respiratory arrest. Number 2 is massive hemorrhage.
exsanguination.
Okay. So you should first control bleeding control and then go for airway breathing.
Yes.
CAB.
Okay. Then continuing with the procedure. So we have administered fentanyl and supplement doing bag and mask ventilation to assist with ventilation. His saturation has improved to 100% with supplemental oxygen.
How will you use the bag mask ventilation?
we apply an adequately sized, appropriately sized mask is chosen and applied over the patient's face, and should cover the nose and the mouth completely. If the patient is edentulous, you can put the lower lip, put the lower part of the mask inside the lower lip, and then supplement oxygen through bag and mask ventilation. You have to compress the bag up around 1/3 of the bag is enough to deliver a tidal excursion, to proper tidal excursion. So improve the breathing by giving bag and mask ventilation around one breath every 5 to 6 seconds would be sufficient.
Is the patient having any denture?
He had dentures. There was no artificial dentures.
Okay.
He had normal teeth. He was not
the
eating.
patient is coming with a removable denture.
We have to keep the dentures and then give bag and mask ventilation. And during intubation, we have to remove the dentures.
Okay. Ventilation with the denture and
Intubation without the dentures.
Okay. See, you are telling every 6 minutes you are giving one breath.
Every 6 seconds. 5 to 6 seconds.
Okay. See, usually there are two things you have to look into this whenever you are using a bag mask.
Yes.
One, the adequate
Chest rise.
chest rise.
Yes.
See, that optimal chest rise is enough. So there is no the thing 1/3 of the bag is used or half the bag or complete bag. So you should use the bag in such a way that seeing every time you are using, you have to
Look for
inspect
equal
the
chest rise.
chest rise.
Yes.
So it should be an adequate optimum. This one is enough.
Yes.
Not overdoing also, because overdoing, what will happen? Overpressure if you will.
So the transthoracic pressure will increase, so the venous return to the heart will decrease, and that will cause worsening of the circulatory collapse.
Any other
Even
thing?
it can affect the brain also.
Yeah.
Any other thing?
If you hyperventilate, the chance of aerophagy, that means the air going into the esophagus and causing gastric aspiration, is also very high.
See, going into the stomach, distension of the stomach and the vomiting and subsequent aspiration, these things may happen.
Yes.
So you should not unduly overpressure.
Hyperventilate.
And most important thing, every inspiratory effort, you have to gauge it. At the starting of the inspiration, you have to squeeze the back.
Yes.
Okay, that the synchronized assistance should be always given.
Yes.
It's not going along with the number of times your breath in a minute.
When patient is apneic, you can.
Apneic, this is called a controlled ventilation.
Yes, sir.
This is an assisted. Whenever he requires, you are going to give. So during the time of starting of the inspiratory effort, so you just squeeze the back.
Okay.
And it should be coinciding with the inspiration, then leave it.
Okay, sir.
Okay.
Then bag and mask ventilation was going on, and then we have also administered the induction agent, which is etomidate. We have given 20 milligram as slow IV, and to avoid pain at the site of injection.
How long did you ventilate?
Sir, pre-oxygenation for 3 minutes.
How much oxygen you are keeping?
15 liters O2 with bag and mask. So around 100% FiO2 we are administering.
Okay. Have you been monitoring the SpO2?
Yes, we have continuous SpO2 monitoring was also been going on.
So what was the?
His saturation was 100%.
100%. Okay.
So then
ventilation along with the monitoring should go together.
Yes.
Okay.
Then after this thing, then we have proceeded with positioning with paralysis. We have paralyzed the patient.
No, first what did you give?
Induction agent.
No, before that?
Before that, pre-medication.
What is that one? What is the dose?
Fentanyl 3 microgram per kilogram body weight I have given.
Okay. See, how many minutes before? Just before or?
Sir,
minutes before?
Around before we gave the induction agent we have given. So 2 minutes before the induction agent we have given. Then after that, paralytic agent was given. Paralytic agent was chosen was rocuronium. I have administered 50 milligrams of rocuronium and positioned the patient. And at this point, at this point, apneic ventilation was going on for 45 seconds for the action of rocuronium to act, and then we proceeded with intubation. We have intubated the patient with a size 8 cuffed ETT, and the angle of mouth was 19. And the tube was secured with tapes and avoided neckties.
What are the things you after intubation? What are the things you have to inspect on the patient, and what are the investigation you do immediately?
Sir, after intubation, you have to confirm the position of the endotracheal tube by 5-point auscultation method and waveform capnography. Waveform capnography remains to be the gold standard.
That is very important.
Yes. So we have to look for a waveform capnography, and adequate waveform capnography should be looked, and it should be in the range of above 35, in the range of 35 to 40 millimeters mercury. And then we should also look for look at the saturation. We should do the 5-point auscultation. We should auscultate the left epigastric region. First, auscultate the abdomen to look for the air is entering the abdomen. Then look for the lower chest and then the upper chest. And also, it is advised to check for the axilla also, because sometimes if it is a single lung ventilation, you can hear the air entering from the opposite lung to this lung.
Even then, you want to take an X-ray?
Yes, we have to confirm with an X-ray, and a continuous waveform capnography should be done.
What information you get from X-ray?
X-ray, you can look for if it's a single lung ventilation. That means if it's a main bronchus, or if it has gone into one of the main bronchus, right or left bronchus, and if there is aeration of the lungs and all.
What ventilatory settings you kept for this patient who is having higher suspected ICP?
Sir, this patient with suspected ICP, I've selected a volume control ventilation with adequate minute ventilation, above 8 liters per minute, to maintain eukarbia, normocarbia. So the ideal setting would be to a volume control or a pressure control ventilation with we should avoid hyperventilation or hypoventilation.
Okay.
And we should avoid hypoxia, because hypoxia and hyperoxia both can cause secondary brain damage. So we should maintain normoxia, that is in the range of 80 to 90 millimeters of mercury would be adequate of oxygen.
Have you done any imaging for this patient?
Sir, after intubation of the patient, we have taken a chest X-ray, and we have also asked for an immediate CT brain plane.
What was the CT finding?
Sir, CT brain plane revealed a CT brain showed a I'll tell you the reading, sir. It was a non-contrast CT which showed bilateral ill-defined hypodensities in parieto-occipital regions, left-sided more than right. Could represent a infarct, suggested MRI stroke protocol for further detailed study.
Suppose it's an infarct, you have intubated this patient. What is the next treatment option which can be given from emergency room?
Sir, if it's an infarct, if it's an ischemic stroke, we have to maintain the BP. We should not reduce the BP below 180 by 105 to preserve the ischemic penumbra, unless we are going at with the thrombolysis. If the patient arrives in the period of less than 3 hours ideally, or extended hours less than 4.5 hours, we can offer the patient with thrombolytics. But this patient has been found unresponsive since a long time, and we don't know a proper history when it was. So with the available CT, which showed bilateral hypodensities, ill-defined hypodensities, and they asked for an MRI to look for further events.
What are the other treatment options available for this patient who cannot be thrombolized in emergency room?
So this patient who cannot be thrombolized in the this thing, we should start with neuroprotective agents and avoid secondary brain damage.
Okay.
And we should keep the patient in a 30-degree propped up position. Propped up, head end should be elevated, and neck should be in a neutral position. You should avoid neck lines, central venous catheters, etc., that can impede with the jugular with the venous return. So we should then, if the patient is having signs of severe cerebral edema, we should give osmotic diuretic agents such as acetazolamide, mannitol, etc. Mannitol should be given as a bolus. Should be given over 10 minutes. Then hypertonic saline also confirms.
Okay.
And there is no role for prophylactic anti-epileptics unless the patient had a definite seizure or patient is having epileptiform waves in the EEG. Continuous EEG monitoring is also required for this patient.
Do you want to do an echo and a Doppler study for this patient?
Yes, we should do an echo and neck vessel Dopplers also. We should echo to look for any mural or left ventricular apical clot, etc., which could have embolized to the brain, and you should look for Doppler to look for neck vessel stenosis.
What is the role of heparin in this patient?
Sir, if the patient is having heparin can be given for two purposes, one for DVT prophylaxis and other for
If there is a clot originating
from the
heart,
LV apical clot.
there is a-
Yes, that
so
is
you have
it.
presented the case
Yes.
and treatment was okay.
Okay.
Thank you, sir, for enlightening for us about the intubation and intubation protocol. Thank you, sir.
Most welcome, sir.
Thank you.
Most welcome.